public health tools that help solve our health challenges. One of the ways we do this is in looking at the environment in which the research and the product development, as well as product introduction to the market, is conducted. And we advocate and support the advocacy for issues that are going to make this environment better. And the issue that we are advocating in this Africa Health R&D Week now is the sustainable financing of research, health research in Africa, so that we can have contextually relevant products for our public health. John, could you support me with muting? Thank you so much. The challenges of our technology. Yes, so as I was saying, one of the issues that we are advocating is the sustainable financing of health R&D in Africa, so that we can have contextually relevant and priority public health tools that suit our challenges and our communities. In this conversations we've looked at this issue of domestic resource mobilization from different angles. On day one, we looked at being accountable with the resources that we have. Yesterday, we were looking at what impact does debt have on our being able to mobilize resources for health R&D. And today, we are going to look at innovative approaches to domestic resource mobilization. How can our governments find more resources for health research and development? And how can we tap into the public sector, the great resource that is within the public sector? So to take us through today's conversation, to moderate today's conversation, is a friend and colleague, John Mead, who works with IAVI and leads programs within a coalition that IAVI manages, the Coalition to Accelerate and Support Prevention Research, CASPR, which IAVI is a part of. So I'm going to hand it over to John and let him tell you a little bit about CASPR and the work we do collaboratively, and then also take us into today's conversation. John, over to you.
Thank you so much. Excuse me. Thank you so much, Ethel, and welcome to everyone to day 3 of Africa Health R&D Week, right? We've had, as Ethel mentioned, we've had 2 amazing days, first talking about accountability and ensuring that African governments are held accountable for the commitments that they made, right? The second day, yesterday, was talking more about the debt burden, progressive taxation, and really hearing from our colleagues at UNAIDS and an amazing advocate in Amanda and also Tax Justice Africa to really walk us through some of the innovative strategies and other sectors that we can pull in to this DRM work and activism that we're engaged in. But today, we're really going to hear from really all parts of the continent, really, to talk about innovative strategies for domestic resource mobilization. What is the private sector involvement? How can we involve private sector? What can advocates do to really find innovative ways for increasing investment in domestic resource mobilization? As Ethel mentioned, this week, and I'm really involved in the CASPR program, the Coalition to Accelerate and Support Prevention Research, which is funded by the U.S. Agency for International Development here in the United States. And we are a coalition of multiple organizations, I think over 20 partners in sub-Saharan Africa that work not only in DRM, but also to work on HIV prevention research, raising awareness, research literacy among advocates, so that advocates can go out and advocate to pharmaceutical companies and to governments and to researchers and research institutions. And one of the main pillars of we need the research funded, right? The research needs to be funded by someone. And currently the funding majority comes from outside external sources, outside of the continent sources, such as the United States National Institutes of Health. The US Agency on International Development has a global health arm that works on research. The Bill and Melinda Gates Foundation. There are a lot of outside sources that really come in to fund research. So how can we get governments, African governments, to invest in their own citizens, the health of their citizens, right? This is an important question, and we're gonna hear from some amazing speakers. First, we're gonna head over to Nigeria, right? And we're going to hear from Dr. Francis Elika. Dr. Francis Elika is an experienced public health practitioner, researcher, health systems expert, health economist, and program manager. She has a medical doctor degree from Nigeria and a master's degree in public health, health economics, as well as a diploma in public health from the prestigious London School of Hygiene and Tropical Medicine. She also has additional training in leading in health systems, advancing health systems, sorry, give me 1 minute. Advancing health financing for low middle income countries, building resilient, sustainable healthcare systems, and advancing universal health coverage and implementation research from the World Health Organization and Harvard Chan School of Public Health. She has provided technical and managerial leadership in several donor-funded development projects at senior levels, which led to advancement in health system reforms, including the Basic Health Care Provision Fund, health insurance schemes, design and implementation, primary healthcare strengthening, public-private partnerships, domestic resource mobilization, and implementation of key partnerships, of key RMA and CH, HIV, TB, and malaria interventions. In addition, she also has prior clinical practice experience at several levels of the health system, which gives her a firsthand understanding of the issues of the health system. Some of these projects include a multi-million-dollar partnership for transforming health systems. It's also a USAID, the United States Agency of International Development funded health financing governance and the Health Policy Plus projects. She is currently the Global Director of Health System Strengthening at Palladium and provides leadership support on advancing locally led approaches on the USAID Propel project in Africa, Asia, and Latin America. So I will hand it over to Francis.
Thank you very much, John, for that introduction. I'm really happy to be here. And today I'm excited to be joining like-minded Africans and friends from all over the world to talk about these issues, because it's quite clear to all of us that the solutions to African problems must come from Africa, and we have to devise homegrown solutions to our problems. And for us to be able to do that, we must work together and we must unite to find these solutions without waiting for someone else to solve these problems for us. I think the saying, the African saying that when you want to go far, then you should go with others, and that it takes a village to actually get something done is actually much more true in this scenario than in others. So today I'm excited to share with you some of the experiences from the USAID funded Health Policy Plus project. Of course, we are talking about Africa. Africa belongs to us. We're all committed and passionate about leading Africa to development and to prosperity. But we all know that there are many challenges and problems that we face as Africans. First of all, it's common knowledge that the global disease burden is mostly in Africa, whereas the way that we fund our health systems is not commensurate with the burden of disease that we have. So for instance, 25% of the disease burden is in Africa. However, less than 1% of global health expenditure comes from Africa. The same applies to the global per capita expenditure on health, where most African countries are performing way below the recommended threshold of $86 per capita. The same thing happens to the African, the declaration, the Abuja Declaration on Health to act for Africans. This was actually done in Abuja, Nigeria, where many African countries signed on to ensuring that 15% of the health budget is dedicated, of the national budget is dedicated to health. But this is yet to happen in many African countries. Of course, when it comes to manufacturing, less than 2% of the medicines we consume are actually manufactured by us. The rest we have to import. And then, of course, less than 2% of the global research output is from Africa. Even then, it's still varied, with some countries like Egypt, Nigeria, and South Africa responsible for most of this research. So what must we do to change this scenario? Sorry, I'm having a bit of a lag in moving my slides. Can we get some IT support? Sorry about that.
Yes, no worries. I can show your presentation, actually. I have it up.
Great.
Perfect. I will share now.
Okay.
Perfect. And I will. Perfect.
Apologies for that. Yes.
No worries.
Yes. So there are a lot of mechanisms that have been tried in the past to raise additional resources for health all over the world, as well as in Africa. Some have focused on looking at sin taxes. Some have focused on methods like blended financing, social impact bonds, diaspora funding, looking for ways to tax and earmark funds for health. While some other African countries have actually been more successful in getting more taxes dedicated to health, which is usually projected as the best method. But of course, we all know the big problem that we face in Africa, where the bulk of the population comes from the informal sector. So to a large extent, many of the countries are not able to generate up to 10% of their GDP as tax. So general taxation is unable to fund most interventions or most needs of the government, and health, of course, suffers as a result of it as well. But today, I'd like to make this as practical as possible. Next slide, please. By actually looking at how we can fund the health sector using mechanisms that have actually been practiced or have been tried out in many parts of the world. So today I'll be sharing experiences from the Health Policy Plus project funded by USAID, especially the work that we did in Nigeria. Now, there are some very important things that we need to note with regards to innovative financing. Innovative financing as a standalone, most times is not sustainable, and most times they are not successful. So for them to be successful and sustainable, they need to be integrated within existing systems. They need to be an additionality to already existing public, private, and other mechanisms of funding. And they actually need to be integrated into existing health sector infrastructure and ecosystem for it to be successful. So why do we want innovative financing? Most times, because of economic downturn, because most African countries belong to low-income countries or middle-income countries, the questions that we get from politicians and from leaders is, where will the money come from? So innovative financing, ideally, is supposed to improve the already available resources, including from government, from private sector, as well as from external sources. It is also supposed to catalyze and get additional resources for us to be able to achieve our health goals for health interventions, as well as for R&D. But in addition, it should also stimulate efficient use of mobilized resources. So we're talking about more money for health, as well as more health for the money. So making sure we get value for even the limited resources that we have. And this should be a mix, like I mentioned before, from public financing, prepayment mechanisms, innovative financing, as well as external financing, because we cannot completely do away with external financing until we get to that place where we have everything that we need to be financially sufficient by ourselves. But that said, ownership and leadership must actually come from governments if we want to be successful. Next slide, please. So the Health Policy Plus project actually worked across 49 countries and was able to raise over 1.9 billion US dollars through domestic resources. And this was done through many projects and partnerships with different people. Next slide, please. But today I would like to focus on our experience in Nigeria. So to give you a little bit of a background, Nigeria is the biggest country in Africa. It's often said, some people will say 1 out of every 4 or 1 out of every 5 African is a Nigerian. So, and there's a common saying that if we can get it right in Nigeria, then we can get it right anywhere else. So Nigeria, large population, we're on track to actually double our population by 2050, which is quite scary. However, over 53% of people live below the poverty line, and we still have the highest rate of out-of-pocket spending. What that means is that it's inequitable. So if you do not have money in your pocket, there's a high risk that you will not be able to access healthcare, and you could actually die as a result of that. And also, we have one of the lowest levels of insurance coverage at about 4%. So the Health Policy Plus project actually provided support to governments to advance domestic resource mobilization efforts. As a result of this, we were able to achieve over 80 million US dollars in additional resources mobilized for health. We also helped to coordinate implementation of key policy reforms that had been lying on the shelf by engaging effectively with key stakeholders. And very soon I'll get to share with you some of the approaches that we used. We also supported the development of a national HIV policy to raise additional 662 million US dollars over the next 5 years for HIV provision. But in addition to that, we make sure that key reforms like health insurance that would make sure that more people have access to healthcare services were put in place, and that people were enrolled and began to access care to priority health interventions, including HIV, AIDS, TB, and malaria. Now, focusing a little bit on the work that we did around HIV, AIDS, support for domestic resource mobilization. Nigeria, like many African countries, is highly donor dependent for funding its key priority interventions like HIV, AIDS, TB, and malaria. And gains from donor funding, of course, is not sustainable, right? So the funding is not sustainable. A lot of gains have been made, a lot of reliance. But for us to be able to have a more sustainable system, there is a need to move away from donor funding into more improved local ownership, financing, and sustainability. For us to, first of all, close the financing gaps, as well as make sure that we have a sustainable in the future. Next slide, please. So with regards to some of the things that we did, we supported evidence generation, which is why research is very important. Because one of the first hurdles that we met is that general belief that HIV/AIDS is a purview of donors. And so the government didn't need to spend money on it. The government would actually rather spend money on other things because they believed that HIV/AIDS was covered by donors. So one of the ways to change that narrative was to generate adequate evidence, including user fees assessments, to actually see the number of people who were accessing HIV services and the fact that these people still incurred additional expenses despite the fact that these HIV services were free. This was, of course, as a result of both direct and indirect fees, as a result of the fact that there were a lot of gaps in service delivery, especially at the primary healthcare level. So these healthcare workers actually demanded fees from people despite the service being free. Of course, we conducted a lot of other situational analysis, looking at the public financial management system, the way that the funds flow, in trying to identify what the obstacles were with regards to funding HIV/AIDS as well as research for HIV/AIDS. We also did a lot of assessment, trying to look at local capacity for manufacturing of HIV/AIDS commodities, as well as a general situational analysis to find out where the monies will come from, as well as what key interventions were necessary to move the country forward. Next slide, please. So armed with this evidence, we supported a multi-sectoral group of stakeholders to develop key policies to enhance sustainable financing for HIV/AIDS. One of them was the development of this game-changing National Agency for the Control of AIDS Domestic Resource Mobilization and Sustainability Strategy, which will run from 2021 to 2025. As I speak to you, this policy is actually being implemented in many states in the country. Lagos states, which HP Plus supported, was one of the foremost states that actually started implementation of this policy, and we'll get to hear more about it very soon. Another very important policy that we supported was a blueprint that actually provided guidance for integration of HIV/AIDS into health insurance. So Nigeria has this big UHC strategy of expanding health insurance coverage across board. And it was very important that a priority disease area like HIV/AIDS was included. And so this policy was actually very important to make sure that stakeholders had a clear idea and clear plan about how to go about doing this integration. Next slide, please. So this is actually speaking to giving a broad overview of the domestic resource mobilization strategy that we put in place. And this resource mobilization strategy was actually holistic and was integrated into an already existing system. Like I mentioned earlier, for innovative financing methods to be successful, they need to be integrated into existing ecosystem and existing infrastructure, existing government institutional structures to make sure that these efforts are sustained. If not, they become one-off interventions, maybe from donors or from civil society, that dies off at the end of the day. So we needed to make sure that that happened. And that was one of the reasons why we supported the government to develop this resource mobilization and sustainability strategy. One of the key provisions of that strategy was looking at public sector mainstreaming. So how do we ensure that government meets its commitment to fund HIV/AIDS in the country? So this actually looked at how we can increase budgetary allocation to AIDS and healthcare. We also looked at how we can integrate HIV services into already existing services, as well as into the basic healthcare provision fund. And then we also went beyond the public sector to look at the private sector. So before now, the private sector contributed about 1% of the national funding for HIV/AIDS, which is quite minimal. So this strategy is looking at how can we raise private sector contribution from about 1% where it is now to at least 20% within the next 5 years. And some very innovative mechanisms were actually developed. One of them is this very promising HIV/AIDS some of them include, getting additional resources through the diaspora funds, the HIV/AIDS Trust Fund. Now, the HIV/AIDS Trust Fund is actually a fund that will pool resources from private organizations towards advancing HIV interventions. This trust fund is actually going to be run outside the government system, and it will be run by private sector stakeholders in order to enhance trust, accountability, and actually make sure that it's effective. Because of course, we're all aware of the trust issues that exist between private sector and the government. So this HIV/AIDS Trust Fund was actually set up to raise about $150 million in the next 3 to 5 years. And then of course, the private sector engagement will strengthen philanthropic investment in the HIV program, mobilize resources through diaspora funds, as well as expand private health insurance to include HIV/AIDS. But in addition to this, we also knew that it was important to make sure that even the little resources that we have already is efficient and effective. So there were also pillars that looked at how do we ensure efficient and effective HIV response through financial transparency. So this was the part where we had civil society members involved, private sector, community groups, people across all board playing a role to make sure that there is actually transparency, that there is accountability, and that we have good value for money. And that these services that the government actually provides, that is actually happening at the community level. And then of course the governance. So we had to do a lot of institutional strengthening, including building capacity of key health sector actors to effectively engage their counterparts in the ministries of finance, in parliament, as well as all the other places where they could actually attract resources from, including the private sector. Because even you actually find out that the public sector most times do not even know how to communicate with the private sector in a manner that they would understand, or in a manner that they would actually be incentivized to contribute towards what is happening in the health sector. And of course, this leveraged the civil society organizations to conduct resource tracking. So we put mechanisms in place for AIDS health accounts, the state's health accounts, resource tracking, budget tracking, to actually see that government is releasing the budgets that had been allocated, and actually making sure that these are spent in a more efficient manner. So for instance, moving away from spending all the allocations on program management and trainings to actually making sure that they are going towards, things like purchase of HIV test kits, for instance, building capacity at the facility level and other things like that. So of course, one very important aspect that came out, which of course COVID helped to shed a very good light on, is regards to local manufacturing of commodities. So this has been quite topical. So this was one of the innovations that we actually found to be that if we are actually able to support government to do this, it will be effective in actually turning things around. For instance, during the COVID pandemic, there was a very long lead time before the drugs actually came into the country. So this led to, people having difficulties accessing their drugs and all of that before a lot of measures were put in place. Of course, many of us are aware that before the COVID vaccines got to many African countries, that the places where they were manufactured actually got them first. And of course, we know what that cost us. So a lot of conversation has gone into research, looking at how do we get Nigeria and other African countries to actually manufacture the medical products that we need, so that we can be ready for, our day-to-day essential healthcare needs, as well as the next epidemic that may actually come. Next, please. So as a result of this, we were able to provide support to develop this very important strategy that everybody sees as the game changer that can mobilize additional 662 million for HIV/AIDS in the next 5 years, as well as $150 million from the private sector. In addition to that, we actually saw budget performance triple in, for instance, a state like Lagos State, where their budget allocation as well as releases tripled between 2018 and 2022. This is actually quite unheard of, because I'm sure that many African countries have similar challenges of even when resources are allocated, because for the most part, most of these budgets are not realistic. The government is not able to make as much money as it's budgeting. So a lot of times budgets don't get executed, MDAs don't get funded and all of that. So being able to work across board, and I'll get into the details of how we did all of this very soon, to make sure that we had adequate resources allocated for HIV/AIDS and health, but also making sure that these funds got released, and that when they were released, they were actually used in a more efficient manner, even down to the community and facility level where the effects were most seen. Next, please. So in addition to that, we also provided support to make sure that the health insurance coverage in Lagos State was actually where it was enrolled into the health insurance scheme, so that they could access healthcare needs that they actually needed and have access to these healthcare services. Because it's one thing for the healthcare services to be available at the facility level. It's another thing for people to be able to access it. So what the health insurance scheme does is that it removes the financial barriers to people accessing healthcare. And we're quite innovative in this, in that we targeted poor and vulnerable people. So over 300,000 poor and vulnerable people who couldn't pay were actually enrolled into the scheme using government funds called the equity funds. So for instance, in a state like Lagos State, this is about 1.2 billion naira per year. And this actually also targeted orphans and vulnerable children, key populations, which we know that in Africa, for the most part, most times, there's a lot of stigma and issues with our key populations. But we're able to work with and engage the government effectively to actually get key populations, including those who are poor and vulnerable, to be covered through the health insurance schemes. Next slide, please. So what were the things that made our approach successful? First of all, there was a focus on sustainability from day one. So like I keep mentioning, one-off pilots, innovative approaches oftentimes don't work because they may come and become fungible. They may, once there's an earmarked fund, government takes away every other fund, and then it's just that fund that is there. And if after a while, there's no political will to continue that fund, then everything fizzles away. So it needs to be built into the system in a sustainable manner so that that funding continues to come in a stable, predictable, and sustainable way through the years, even when there's change of government or when anything happens. So that was one of the things that we did from year one. We made sure that it was locally driven. We strengthened capacity across all levels, from the federal level to the state level down to the community level. We used evidence to drive this information. So for instance, people at the ministries of health at every level were able to generate their own evidence and use this evidence to engage people at the ministries of finance and parliament, as well as even within their own ministries, to make a case for why health sector needed to be funded. And this for us was actually something quite important that we saw led to improved results. Of course, it needed to be integrated. So coming off to say, for instance, in our own case, even though that this funding was coming from a HIV focus, it actually strengthened the whole system because it strengthened the health infrastructure, it strengthened the information management systems by ensuring that they had very good, robust ICT systems for capturing health information data across board. We also made sure that there were policies that were developed, and this was multi-level. So from national level to state level to facility level to community level, including ward development committees. This, for instance, is one of the communities. You can see that there are health workers, but there are also other people from the communities. That was the holistic approach that we used to make sure that this was sustainable. There was citizen involvement, and there was transparency, accountability, and all the other things that were needed to make sure that they were sustained beyond this intervention. Then, of course, one very important one is multi-sectoral collaboration. We all know that the funds to the health sector does not come from the health sector. And oftentimes the health sector actors are not well capacitated or well positioned to negotiate or to fight for these scarce resources. So multi-sectoral collaboration became a game changer where we actually built capacity, both individual, institutional, as well as relational, for them to be able to relate effectively and speak the language of the finance people, speak the language of parliament, speak the language of politicians when they are trying to get them to invest more in health. Then, of course, our approach was also holistic, and it involved institutional capacity strengthening, which is one of the things that will make it sustainable. So we had, next slide, please. We actually had multi-sectoral technical groups that were set up. And these multi-sectoral technical groups were made up of government, including people from government and actors from ministries of finance, from health, from parliament, including private sector actors, including implementing partners, CSOs, who actually played a very big role. And this was institutionalized within the Office of the Department of Planning, Research and Statistics in the Ministry of Health through what we call a health financing unit. So this health financing unit then became the powerhouse. They generate the research, they generate the evidence, and they share this evidence with the CSOs, with the ministries of finance, parliaments, and other people, and they use it to advocate for more resources to be used on health. So this was actually found to be very effective. And then, of course, the ministries of finance and parliament, as a result of this improved relationship with health sector actors and improved understanding of how the health sector works. Because before now, when we started these conversations newly, people from ministries of finance would say that they've always seen the health sector as a black hole where they just put in money and they don't see any results come out of it. So there needed to be a lot of discussions, a lot of transparency. Health sector actors learned that they needed to be more accountable for the resources that they are given, show and demonstrate results with the resources that were given. And then the people from finance and parliament actually learned more about why it was important to invest in health and how this contributed to their own goals of poverty eradication, employment creation, economic growth, and all of that. And then, of course, it became a beautiful match as all these different sectors actually turned to very strong champions and advocates for the health sector. Now, other things that were done was also making sure that the health financing unit, which was driving the research that was used for this, was actually funded. So a budget line was created for the health financing unit for research, for state health accounts, for budget tracking, and all the other things that they needed to do to make sure that there's adequate evidence to be used to generate, to engage different policy decision makers, politicians, as the case may be, across all levels. And this was actually, for me, perhaps the most important ingredients to the successes that we recorded on this program. Now, what are some of the lessons that we learned from this engagement? Of course, one very important lesson is that aligning with existing government health financing policy is very important. So I'm sure all of us are aware of the conversation around decolonizing global health, locally led approaches, localization. HP Plus project actually started doing this a very long time, even before these topics actually became popular. So we made sure that the work that we did aligned with government policy. So for instance, in Nigeria, there was a basic healthcare provision fund policy that had been there, but it had been sitting on the shelf because of political economy challenges. So one of the things that we did was that we provided support, mentoring, and handholding to government actors to actually pick up this very important policy and then have those very hard discussions, including agencies that were not getting along very well with each other, to have those discussions around how do we move this forward. And then a model was developed and then it was rolled out. And as a result of this, the 4 states that we supported were the first states that actually met the criteria to implement this very important policy, which saw financing flow for the first time down to the primary healthcare level. And people, women, poor and vulnerable people were actually able to start accessing care as a result of this. So it's very important to make sure that the policies are aligned with government interventions. If not, once you're done with that intervention, everything ends there. But then it needs to be locally led, it needs to be integrated within existing ecosystem and infrastructure. I cannot say that often enough. Now, other lessons learned is that there is need for evidence. So we found how important it was. We often complain that we don't have adequate evidence for decision making, but the little evidence that we were able to generate working in collaboration with government partners, we saw the power, the massive power that it had to turn things around, to change things, to convince people. We were actually, at the time we started, we were at the point where the Ministry of Finance was about to take away all HIV funding and take it somewhere else because of the bad economy, saying that HIV was being funded by donors. It was evidence that changed their mind, from not just allocating, leaving the money there, but they even allocated more and more. They tripled the budgets that was supposed to go to HIV/AIDS. So evidence is very important, and we must keep talking about how to use evidence to drive decision making. So participation, inclusion, making sure that there is intersectoral action, like I mentioned before, is very important. Cutting across all the key important sectors that have a role to play in order to make sure that we get the results that we seek. Then, of course, understanding the political economy. I had mentioned a little bit about this before. So who are the people with the interest, with the influence? What interests them? What are the incentives? How can we find the win-wins? How can we get them over to our side? And, it's actually amazing when you find the right language or the right conversation with people to see someone who used to be what we call a blocker actually turn into a champion for something that is very important once that person understands how he or she benefits from it, or how his community benefits from it, and so on. So of course, it takes some efforts to build trust, to build relationships, as well as to strengthen capacity that is needed for health actors. Because one thing is very common: health actors oftentimes believe that the people from other sectors should know that health is important, so they don't need to explain it to them. But we can't, if that's why we can't continue that way. So health actors need their capacity built, but have relational capacity, how to relate with people from finance, how to relate with people from parliament, how to relate with civil society, how to relate with all the people them, as well as institutional strengthening and individual capacity strengthening. So I'd like to leave you with this, quote from one of the government actors that we supported that led to over 450 million naira released in his states that was used to enroll poor and vulnerable people, including people in orphanages. And these people are now able to access healthcare without any financial barriers. So this was his quotes. Next slide, please. Of course, we couldn't have done any of this without a lot of partners that we work with, and that is why I keep talking about multi-sectoral collaboration. And like we say in Africa, it takes a village. So we must acknowledge the different partners across the different places that we worked with to make sure that these results were possible. Next slide, please. So this instance I shared was actually just a snippet of trying to make it as practical as possible, you know, how we can actually do domestic resource mobilization for health interventions as well as health research and development. So here I've also listed our access to other resources, including other projects that was done by police in other countries, which I think you will find very, very interesting, including methods that included blended financing methods, activity-based costing, and using that to drive evidence and efficiency mechanisms being put in place in these countries towards improved HIV/AIDS control, as well as advancements in family planning, maternal and child health. So thank you so much for giving me the opportunity to talk to you today. Apologies for the technical glitches, and I look forward to the conversations as we all look forward to a developed and more prosperous Africa.
Thank you so much, Frances. That was a very informative and very comprehensive, excuse me, presentation about the successes that Nigeria has seen in domestic resource mobilization. So now we are going to have Linda Mafu from the Global Fund speak with us. So Linda Mafu is the head political and civil society advocate department, external relations and communication division, and is an activist with over 20 years of experience in policy advocacy and partnership development with demonstrated history of working within African and global contexts. She started her career at the Treatment Action Campaign in South Africa, where she developed strategies and worked with partners and stakeholders for policy change. She continued her work as Africa Regional Coordinator for World AIDS Campaign, where she set up a civil society platform on health financing, mobilized resources for advocacy in the sub-Saharan Africa, and used global platforms to raise issues affecting people living with HIV and facilitated dialogues with youth, women, and the health sectors. Ms. Mafu is working for the Global Fund from 2012, and as the head of the Political and Civil Society Department, she leads a team working on resource mobilization to invest in high-impact interventions, as she collaborates with heads of states from implementing countries and champions to support the work of the Global Fund with their voices. Ms. Mafu is a professional PhD candidate at the University of Monarch Business School, Switzerland. She also holds an MBA in leadership coaching and mentoring at York St. John University, as well as an MSc in Human Resources Development at University of Salford, Manchester. So I will pass it on to Ms. Mafu. Thank you so much for joining us.
Thank you so much. I hope you can hear me clearly.
Yes, we can hear you.
Thank you for the opportunity. Of course, I always enjoy having these conversations because they are quite important in terms of shaping what we do. I'm just going to go through the slides. Some of you know that we have been going through a replenishment. And I see some of you are welcoming me in a very awesome way, Womandla. We have been working on replenishment and we have been mobilizing resources, and part of that mobilization of resources include domestic resources. Kindly go to the next slide, please. So when we were putting together our investment case, we looked at what will it take for us to be able to contribute in all the global needs for HIV, TB, and malaria in particular. And we looked at the different global plans, and we landed at a point where we had about 130 billion US dollars needed for the global fund funded countries in order to be able to respond to their epidemics. And in that, we also looked at, so where would the money come from? So the slice for the global fund to mobilize landed at 18 billion US dollars. And some of you know, we have been shouting about 18 billion US dollars as a minimum of the resources that are needed. The second piece, we had 58 billion US dollars that is supposed to come from domestic resource allocation to health. So working with the countries to allocate at least 58 billion US dollars in total in terms of all the countries that we are covering. And that's a very huge amount of money. We also looked at the fact that there were other multilateral organizations as well as bilateral organizations that were providing resources to countries. And that is at a level of 25 billion US dollars. And of course, if you do your maths and you have 130 billion and all these numbers, the 18, the 58, and the 25, you still have a gap, a huge gap of 28 billion US dollars. And that is an unfunded quality demand. That means that if people do not, if we do not increase the allocation of resources, there are people that will not be covered. And we are talking about a couple of targets. We are talking about the universal health coverage that should ensure that nobody ever experiences financial hardship as a result of accessing health. We are also saying that we have all the SDG targets that we want to make sure that by 2030, we are able to realize those targets. Now, coming back to the 58 billion. So for us, as a corporate objective, 58 billion US dollars for domestic resource mobilization is very important. And it is important in terms of, it is going to ensure sustainability of programs. It is going to ensure that healthcare services are available to everyone that needs healthcare services. And without that, we are having a huge challenge. Now, how do we do this? How do we work with countries to get to this number? The first thing that we do with countries and to ensure that we get to a point of reaching these numbers, we have a couple of steps. We have the co-financing step. Next slide, please. We have a co-financing step. So when countries are negotiating and working on their grants, the Global Fund has a responsibility to work with countries around the co-financing policy. And the co-financing policy's role is mainly to catalyze the increased domestic finances allocated to health. We are also working with countries around their transitioning plan, because relying on the resources from donors is unsustainable. And therefore, each country has to have a plan of how they are going to finance their health, how they are going to finance their citizens' health. And therefore, the Global Fund works around that so that we can achieve lasting impact. The second piece around the work that we are doing is to also look at the macroeconomics. How is for instance, we've just had the COVID-19 and has a huge impact on our services, but also had a huge impact on the economy of different countries. And therefore, how do we work with countries around that? How do we work with countries to mobilize the resources, but also to have an assessment of their own fiscal space? That is something that we also work on. So to be able to work with countries, one of the key areas for us is around, like I said, is around the co-financing commitment, which is usually between 15% and 30% in some countries on the allocated programmatic costs. So again, that is very important, because honoring that 15% or that 30% co-financing means that the country has committed and is implementing their co-financing obligation. And that is one of the areas that civil society has to look at and one, monitor, to do a lot of advocacy, because if the country is unable to meet that 15%, then they lose out in terms of their grants. Next slide, please. But also it means that they are not meeting their own domestic resource allocation targets. Now, how do we do the other piece? So there's the co-financing, but also we do a lot of advocacy. We work with countries at a global level, at a regional level, and at a national level. And what do we do? It's a multi-pronged approach where we have different entry levels for advocacy. Like you've heard already, I come from the advocacy department. So my job and the team's job is to ensure that there is useful, strong noise around domestic resource mobilization and domestic resource allocation to health. So we work at the global level and use different high-level platforms, high-level panels, and strategic platforms to raise and ensure that there's high visibility of the domestic resource mobilization conversation, debate, and also making sure that leaders, even at the global level, are holding each other accountable. So we work with the different platforms. We also work at a regional level. At the regional level, definitely we work closely with the African Union. We work closely with the annual leadership meeting to ensure that the leaders at country level, but also the leaders at a regional level, are talking about the resource mobilization, domestic resource allocation to health. Beyond talking, they are holding each other accountable. They are asking the right questions. They are reporting on how they are putting together their resource mobilization plan, but also how they are allocating their resources to health. We use evidence-based advocacy. It is based on the research that is being done at country level in terms of the fiscal space, in terms of the macroeconomics, in terms of how resources are being allocated to health. So we put together the evidence and use that evidence for advocacy. We leverage parliamentarians, and the speaker before me spoke about how they work with parliamentarians. So we leverage the parliamentary networks, working with parliaments to engage with domestic resources, but also when there's a parliamentary debate on budget, we work with parliamentarians so that they are able to ask the strategic questions, to follow up, and to hold the Minister of Health and Minister of Finance, as well as the highest level, which is the heads of state level, accountable in terms of the commitment that they should make. And therefore, for us, that is a very big piece of work. We also work closely with civil society. We have what we call a civil society joint learning agenda, which is focusing on budget advocacy, budget literacy. I come from civil society advocacy for access to treatment, particularly for HIV. And one of the things that really equipped us when we were starting and even in the middle of our activism was a treatment literacy program, so that we could have a good, effective conversation with the decision makers. So again, for us, civil society need to have budget literacy and budget advocacy training so that they can have a meaningful advocacy and a meaningful engagement and be able to hold the leaders accountable. Again, we generate evidence working with the academic institutions to guide us, to provide the evidence needed for us to be able to do the advocacy. Next slide, please. And then in terms of the different platforms that we use the African Union Summit as I have spoken about it at the beginning. We use the African Union Summit because most of the heads of state of the different countries are participating at that level. And we work with them, particularly President Kagame and many other presidents that are leading on the domestic resources, to champion the domestic resource and the importance of self-reliance by African countries. And then also we work with the World Economic Forum, because that is where, one, we get the leaders, but we also get the private sector, because the private sector has to come to the table and they have a responsibility to contribute to the health of the different countries. We work with World Bank, and we use the different meetings that the World Bank organizes, because that's where, again, you meet the ministers of finance. It is the Minister of Finance advocacy is very important, colleagues, because they make the decisions about how or they propose how the resources of the countries are going to be used, and they have to prioritize based on the different arguments. And therefore, one, we work with the health ministers to develop economic arguments around investing in health. We also work with the ministers of health, ministers of finance. Parliamentary summits are used, we use conferences, we use our own replenishment to ensure that we highlight and make the domestic resource mobilization highly visible. Next slide, please. And then in terms of some of the tools that we use for advocacy, some of you may know that the African Union developed a scorecard. The scorecard talks about some of the key areas in terms of how much is the country using or allocating for health, particularly in terms of per capita, how much is being spent, and all the information is in the scorecard, and it can be used for advocacy. The scorecard is updated and reported to at the AU summit. So that is very important for you to know and follow up. You can use the scorecard as an advocacy tool, because it is signed on at a presidential level in the AU. So that is quite important, and the president have to report on this, and therefore, if you have other partners in the country, you can work together on that. We can provide support in terms of providing the information, supporting you around developing some of your advocacy, talking points, advocacy, because you have the tool, the domestic finance scorecard as a tool. Next slide, please. So for us to be able to do this, we also use the Africa Leadership Meeting. In 2019, President Kagame hosted an Africa Leadership Meeting on domestic health financing. And one of the things that he was championing was that for sustainability of health in Africa, we need to make sure that our own African countries are allocating resources from their coffers for health, but also not only allocating those resources, looking at how much are we getting out of those resources? What is the package of care do people get out of the resources that the countries are allocating? So that is the huge campaign that President Kagame has taken up. And on an annual basis, they meet to report back, they meet to discuss and to unlock some of the challenges. And that's also the opportunity for civil society to engage. Next slide, please. We also work at a national level. At a national level, we focus on the national health financing dialogues. So far, we have done the national dialogues in Cote d'Ivoire, in Senegal, in Benin, in Kenya, and recently, I think last week, we did one in Malawi. And there's a plan to roll it out to other countries as well. And we can take, my team member, Theo and Susanna are on the line as well. And we can work with you to update you in terms of if it's coming to your country. So it would be good to continue the conversation, John, so that we know that maybe if the next national dialogue is going to be in Zimbabwe, how do we engage civil society partners that are based in Zimbabwe to ensure that they are part of the conversation? So firstly, the national dialogues are led and owned by the government. So the participation, it is at the highest level, which is at the presidential level, as well as at the ministerial level. The donor countries are also responding and supporting the donor community, are participating in that. And civil society is also a key stakeholder in that conversation. So the national dialogues, colleagues, are very important for you. If, for instance, you reside in the different countries that I have called already, which is Cote d'Ivoire, Senegal, Benin, Togo, and Kenya, as well as Malawi, and you have not been part of this conversation, we can follow up from our end so that you get the report and you have an understanding of where things are in terms of your national dialogue. Mainly the national dialogue are an opportunity, one, to strengthen the country relationships in terms of all the different stakeholders, including the Minister of Health, the Minister of Finance, and parliamentarians, as well as civil society. So we combine all the different stakeholders to have the conversation and to continue, therefore, holding each other accountable. We look at, how do we then ensure that there's accountability? How do we work with civil society, for instance, to follow up after the national health financing dialogue, which is very important. Ensuring that HIV, TB, and malaria are not left behind. They are part of the discussion. They are also high on the agenda because there are many competing issues there. And also making sure that there's a longer term plan for sustainability, because imagine at some stage you don't have a global fund, you don't have many other multilateral donors. What would happen to health if we are not planning now to ensure that there's a longer term sustainability plan? Next slide, please. So that's the kind of advocacy that we work on at a national level. Of course, civil society and parliamentary engagement for domestic financing is very important for us. One, civil society do a great job in holding government and donors accountable, so that is very important. It's important because you have civil society coming from all the different angles around health issues. However, when they are bounded by the issue around universal health coverage, which covers everything. It's not about HIV, TB, and malaria, but it's about research and development. It's about vaccines and access to many healthcare things that we need. And therefore, we work with civil society around that. We work with civil society so that they are part of a planning process. They are part of influencing the national priorities. They are part of influencing the allocation of domestic resources to health. But that is important because if, for instance, civil society waits until there's a budget announcement, it doesn't help. The advocacy needs to happen before that. And therefore, we work with civil society in a way that, one, they understand the entry points to influence the budget dialogue. They understand the timing of when to influence the budget, but also after the budget process, checking how the spending is happening and ensuring that there's transparency. So that is quite important for us. Who are the civil society partners that we're working with? We work with the Global Fund Advocacy Network. We work with national civil society that work on health and other sectors, including human rights and youth, as well as women. We work with faith-based organization as well, because they do have an influence. We work with academic offices so that we get the information. The institutions support us with the information that is needed for advocacy. So we have all the different platforms for civil society, including the Joint Learning Agenda platform, as well as the National Dialogue. Parliamentarians, you know that we work with them at the Pan-African Parliament level, at the SADC region, at the regional bodies that are supporting parliamentarians. We also work at a national level. We have many countries that have health portfolio committees, so we work with them. so that we ensure that they influence the discussion in Parliament. Next slide, please. Opportunities for civil society and IAVI collaboration, which is very important for us. So at civil society level advocacy, we have the Global Fund Advocates Network, and we will share the plans in early 2023, because now we are going through a process of reviewing the replenishment advocacy and our spotlight in 2023, 2024 is domestic resource mobilization advocacy. And so we will be focusing on that, and therefore you will hear from us, and we can work with the different country partners to look at how do we do the advocacy at country level. We also have the different high-level events that are coming up, including the AU Summit is one of them. So we will be working on a joint civil society advocacy around that, and strategically look at some of the key moments that we can utilize in the, thank you, I have 3 minutes. Some of the key moments that we can utilize globally as well as regional and nationally. So we will look up to you to let us know. Like I said, the national dialogue in Malawi has happened already. And we can hear from some of our colleagues about what has happened, and they can share with us. We have Maziko that was also representing civil society there. In Zimbabwe, it's coming up in 2023, Rwanda, Kenya, Burundi, and Zambia. So those are the key countries that are coming up. We will also do a regional West Africa dialogue, which will include a couple of these countries. So this is quite important in the pipeline. You will get the slides so that you will know about your countries. The next slide, please. We have limited resources, both in terms of human and in terms of financial resources. However, we need to have the conversation, and we need to know how we take this forward. So like I said, there are many opportunities that are coming up. We have the opportunity to do advocacy at national level because, you know, the budget discussions. We have the opportunity to work with you in preparation for the regional conversations, which is your African Union. But also if you have other you know, regional, sub-regional conversations that are happening, please let us know and we will work with you on that. There's the trainings that are being rolled out in countries, and we can work with you on that as well. It's a marathon, colleagues. It's not a short sprint. As you know, so we keep on doing the advocacy, we keep on making the useful noise. And thank you so much for the opportunity.
Thank you so much, Linda. That's an amazing presentation about what the Global Fund is engaged in, but also how advocates can engage in this process and be heard by their governments and by the AU. And by other important stakeholders. Thank you so much. Please stay tuned for the panel discussion. So next we will have Robert Karanja, who is with us, who is the co-founder and chief innovative officer at Bilgrow Africa and chairman of the steering committee for the Coalition for Health R&D, or CREED. Dr. Robert Karanja is a biomedical scientist and development entrepreneur with 20 years of experience in STEM and development sectors. And he will be speaking more about private sector involvement and how they can get more involved. Robert, are you here?
Am I able to share my slides?
Yes, you should be able to, yes. You're a co-host, so you should be able to, yep.
I think, are you able to see?
Yes, we are.
Okay, oh, super, thank you. Thank you so much, John, and thanks for giving me the easy job after the heavy lifting on just introducing the topic has been so ably done by Frances and also by Linda. As you pointed out, mine will be much easier, talking about how do we come into this as a private sector. Allow me to get this into presentation mode, and then we'll be off to the races. Is this happening? Okay. Ah, there we go. So yeah, as you've heard, my name is Robert Karanja. I wear several hats. Today, I'm wearing one as co-founder and chief innovation officer at Vilgro Africa, and also as the chairman of the steering committee at CREED, the Coalition for Health Research and Development. And it's important to just highlight these two organizations because they really do inform a lot of my perspective in terms of how we come in as private sector.
Robert, I think you've muted yourself.
Yeah, you've muted yourself.
Oh boy, how did I do that? Thank you.
Just when you're getting to the good part about CREED.
Just the good part. Oh,
yes.
Thanks. So I'm gonna slow down a bit and yeah. So yeah. So I was saying I wear two hats, and so on the side of CREED, the question of what do we do? So we are actually a network. We are not an organization, but 26 organizations that have come together to be able to advocate effectively for domestic resource mobilization for health R&D here in Kenya. Started off in 2015, and with a membership that is quite broad, from CSOs, research institutions. We have universities, PDPs like IAVI, DNDI, and of course, private sector actors like myself. And our mission is really to be able to catalyze action on health R&D through coordinated advocacy efforts. And that coordinated advocacy comes from the multiple perspectives that we bring into this conversation. The specific perspective that I bring is that of Vilgro Africa, where we are set up as a for-profit and a non-profit hybrid entity. We do early stage investment, which is where the for-profit angle comes in, and as we're also a business incubator, that's where the non-profit angle comes in, focusing purely in health and life sciences. I also started off in 2015 here in Nairobi, Kenya, and currently working across 9 countries to date, including a lot of work in Kenya, Tanzania, Uganda, and Ethiopia. So if you look at our portfolio of companies or startups, we have 2 typical buckets that they fall into. Either they are digital innovations, mobile apps, tech-oriented, or the invention-based enterprises. And these are typically STEM-oriented, either coming from biotech or engineering in terms of medical devices or diagnostics. And our theory of change is to be able to leverage frugal innovation, want to understand why does it cost so much for certain technology? How can we be able to develop an equally effective technology at a fraction of the cost? And also, how do we deploy it into the marketplace so that it's a market-driven intervention that is scalable and profitable to be able to attract investment.
You're muted again. Robert, you're muted again.
I think I'm being muted because I haven't touched anything. Okay, sorry. So let's try it again. So I was saying over the last 7 years, we've incubated about 40 startups, served about 2.3 customers. And across our portfolio, we've seen startups being able to generate more than 2.8 million in new revenues, creating over 200 jobs, and being able to unlock about $18 million plus in venture capital and impact investment. So our work is typically at the interface of science, technology, investment banking, and the health industry. So looking at what are we up against when we talk about coming into the health sector, Africa is massive, as we all know. It's one continent, 1.3 billion of us. And as has been pointed out, we actually share a disproportionate amount of the global disease burden. And sometimes the magnitude of what Africa is tends to escape us. So I wanted us to just zoom out a little bit and let it sink in that it's a massive landmass. We do have massive challenges also. We do have a lot of chronic hunger. This year alone, I think in Kenya, we have 4.5 million of us that are facing starvation. due to just lack of rains. We've had one of the longest, most severe droughts in I think I'm being told 40 years. And COVID, and this is coming right on the heels of COVID. So you can imagine a double whammy in a sense. And the question is, how are we able to speak to development to overcome these kind of challenges in a sustainable manner? And I think Francis did a great job of, and I think even more so Linda, of pointing out that there's always going to be a funding gap. And I think even when we talk of the SDGs and the amount of money it costs, or the kind of investment that's expected to achieve the SDGs, the reality is that most of it is not expected to come from governments. It's actually meant to come from private sector. We need to understand, how do we flip these challenges into market opportunities? And so the first thing that I ask myself is, are we doing the right kind of research? This data might be a bit old, but I can assure you it doesn't mean that has changed a lot. But if you look at what kind of research are we doing, especially within East Africa, the first thing is you notice that there's been an upward trend in a 10-year period between 2002 and 2011. We almost doubled, we literally doubled our scientific output if you measure it in terms of the number of the volume of publications. And the question then would be, what are we publishing? And you can see our research is actually spot on. Immunology, agriculture, environmental, plant animal science, microbiology. Those are the top 5 areas of publication based on our of research based on our publications, and that's across Kenya, Tanzania, Uganda, Ethiopia. So are we attacking issues to do with hunger? Yes. Are we attacking issues to do with health? Yes. The question for me is, how does that translate to impact? And when you come to look at, for the same kind of period, how did investment across the multiple sectors in East Africa pan out? You can see it's not reflected. Agriculture, we're not doing too badly in terms of the amount of investment, way below even $100 million, number of deals below even 10. And health sector is even worse. But where do you get a lot of investment happening? It's no surprise, it's in fintech. And that story is still the same today. So the question that I ask myself is, how do we change that narrative? And I think the critical thing is to note that when it comes to translating research to impact, we do need to think more about market and market shaping issues and concerns, because need is not necessarily the same as demand. It's not equal to demand. And if you were to look at how health R&D is done versus how fintech is done, we typically have a technology push mindset in the way we come into the health R&D conversation, whereas in the fintech, they actually start with what is being needed in the marketplace. And by market need, I mean things that people are already, what is the market size? What are the products out there? How do you come up with a value proposition that's going to be competitively strong and sustainable over a long period of time? And so it's no surprise that when you talk about attracting venture capital investment, we are nowhere in the picture compared to fintech. And we do need to ask ourselves, how do we borrow a leaf from the fintech sector? How do we get a better understanding of market shaping to inform our health R&D so that we don't come in with a technology push, but we also start to embrace the market pull? And I think a lot of us are quite familiar with, and Ambisa Moyo, she did a great job of speaking about Africa needs trade, not aid. And I think one of the people that has influenced me the most in terms of my understanding and my perspective will always be Professor Carol Morel from Brazil, who was able to depict this picture of how should it work. And this is where a lot of the work that I do, whether I wear the creed hat, in terms of understanding the policies around adoption, access, distribution, affordability, and regulatory IP. So these are the things that we try to tackle in one way or another, even as we talk about being able to unlock DRM in Kenya. But also then we also need to be able to understand how do we play the triple industries out, and how do we bridge the gap between the two. And if we're able to get this right, then what we start seeing is that we really start to build, to transition away from looking at health from the perspective of need, but looking at health as a key economic driver. by understanding how do we build an innovative industry from our research and driven by our research. And of course, this does not mean that we lock out imported technologies, but we should be asking ourselves, when we import a technology, how do we build on that? And how do we leverage what's already existing in the marketplace? And if we're able to do so, one of the key things that I was asked to speak to is, where do we get alternative financing? I think fintech is already demonstrating that this alternative financing exists, primarily in venture capital. Last year alone, we saw about $5 billion in venture capital investment coming to Africa. Of course, this is tiny. At a global level, we're talking about 671 billion. So we're not really even hitting 1%. But the thing is, this was a record-breaking year. And if you look at where we are at in terms of venture capital investment for the continent, it's really taking that, you're going to pick up on that hockey stick growth curve of exponential growth. And we are right at the bottom of that growth curve. So there's going to be a lot of investment coming this way as we cut our teeth, as investors start to see exits and so on and so forth. And the question for me to ask is, how do we position health R&D within this marketplace of ideas, within this marketplace of innovations? It's good to still note that due to COVID, health was actually number 2. Fintech got 90% of all investment last year, but we came in not a close second, a very distant second at 10%. But we're already seeing strong biotech startups that are beginning to speak to the future of this continent. 54Gene from Nigeria, I think, is the trailblazer, and Yamachi Biotech from Ghana that are speaking to addressing the lack of African DNA in terms of the R&D template for drugs and vaccines discovery. And to me, the key thing to also note is that in as much as we are celebrating this initial small success, we still need to ask ourselves, how do we get more domestic capital into this game? Because what happens is investors repatriate their profits, and most of these startups also being forced to restructure themselves and to register either as Delaware Corps or to register in Europe or other tax havens to align with and to de-risk the risk that is seen by investors. So how do we build a more enabling environment for impact investments to actually come into Africa and for IPOs to happen in Africa and the wealth that's created to be retained in Africa? Otherwise, we're going to be seeing within another 10 years a massive capital flight. So we need to be quite aware that this is a hidden danger. The second thing is also to ask ourselves, what's happening within the innovative financing models? And one particular model that has been extremely fascinating for me is thinking about results-based financing, impact bonds, whether it's a social impact bond where the government tends to be the outcome payer or the development impact bonds. These are just an amazing tool right now that are able to fit in hand in glove with industrial cluster development. And the reason I love industrial cluster development is because industrial cluster development really speaks to a triple helix knowledge-driven economy. We've been investing quite a bit in health R&D. We know it's not enough, but even for that which we've invested, the question we should always ask is, where do we get our return on investment? And it's by being able to translate our R&D into industry, into products, into services, and into life-saving health technologies. So currently, the main challenge I see is that most of the conversations we're having about local pharma manufacturing is still being driven by the EPZ mindset, where our governments are, number one, looking for tech transfer from the north, giving tax waivers to attract existing manufacturers to come and set up, not R&D, but just manufacturing. Fill and finish is a buzzword we're hearing for vaccines. And ultimately what we're doing, it's a race to the bottom. We are not getting any taxes. We are competing by providing quote unquote cheap, non-skilled labor. And there's very limited capacity for absorption of the R&D that we are even struggling and asking, where do we get the resources for? But what we really need is a knowledge-intensive, innovative pharma industry that can actually take the health research outputs from our academia, from our research institutions. Of course, that comes with key risks. And the first one is when you're talking about, especially in health sector, health technologies, the technological risk never goes away. A technology can fail in phase 3 clinical trials. A technology can even fail post-market approval. And how do you handle that? And so that is the key reason that makes our governments tend to focus on the EPZ model, where it's more generics, there's no innovation happening, and it's, and you are basically trying to just understand how do you get pooled market commitments, advanced market commitments to de-risk the commercial or the economic risk. And even after doing all of that, then the question I'm asking is why then are we investing in our local R&D? And so to me, coming back to how to structure impact bonds, the critical thing is we need to be able to have an organic cluster development that looks at how do we create spin-offs from our R&D. We are able to speak to the current needs of our governments because we know the issue of debt that we were discussing yesterday is a major issue. It's not going to go away. And through impact bonds, that means the government does not put in a penny because you get investors to come, especially impact investment or DFIs, that can come in and actually take the heavy risk. And government, if we succeed, and how you measure success is something that can be negotiated. And I think especially for cluster development, measuring impact should be fairly simple. How many jobs do we create? Not non-skilled jobs, quality jobs, STEM-oriented jobs. How much revenues are created by the spin-off companies or by the industry that's created, export revenues, so on and so forth. Forex gains. So to me, there's a much simpler way of looking at impact bonds that we should ask ourselves, can we leverage this? If we're doing this successfully for crazy stuff like being able to reduce neonatal mortality or maternal mortality and show attribution to the intervention, I think this would be a much simpler play for many of us. And then lastly, I think we also need to ask ourselves, how do we activate Africa's private wealth? I think on day one, we're asking, where are the billionaires? Where are the millionaires? And this map tells us where they are. So if you're looking at this map from any part of Africa, it's very interesting. The same countries that you saw leading in terms of fintech and investment are the same countries that are going to be having a lot of private wealth within their pool. The big four, Nigeria, South Africa, Egypt, Kenya, are still going to be leading. And the ability to have other countries, Rwanda, Botswana, Zambia, Morocco. So to me, I think there's quite a bit of work that we need to do. But the critical thing is these people didn't become billionaires or millionaires by giving away money. They look for worthwhile investments. And the question we need to keep asking ourselves is, are we a worthwhile investment? So I think with those few remarks, because of the time, I want to say thank you and look forward to the questions and discussion with from the audience. Tomorrow is November 11th. We are going to be having the release of Black Panther. And I can't go away without talking about Black Panther, because what you see behind me is actually a marketplace screen grab from the first Black Panther movie. And I've always loved the fact that they help us to imagine a knowledge-intensive economy that's indigenous to Africa, purely driven by African innovation. And even in health sector, as you can see here. So my parting thought as I leave you is to say, let's reimagine an indigenous African biopharma sector. Let's not take the easy path of EPZ. Let's ask ourselves, how can we maximize the impact that in terms of economic growth and development that we can get from health R&D. Thank you so much.
Thank you so much. And we appreciate you joining us and giving us that very important aspect of the private sector involvement, right? And this ties into the conversation we had yesterday about progressive taxation. Africa has billionaires and millionaires, so progressive taxation could be a good method for increasing revenue, right? And increasing funds for health research. So as I mentioned in the chat, we will be extending the session 15 minutes to make sure that we have some kind of discussion. But right now we're gonna have Walter Chikanye to come and speak to us about, there are some advocate perspectives on how advocates can get involved in promoting innovative approaches to DRM. Walter is a public health specialist, HIV/AIDS programmer with 20 years of research and programming experience, a passionate advocate and activist for increased domestic health financing and domestic health resource mobilization. He holds an MBA and a BSc in statistics and biology, currently engaged as the director of Zimbabwe Community Health Intervention Research. Walter is also part of the Global Health Country Coordinating Mechanism, CSO representative. So thank you so much, Walter, for being with us. And I will share your slides in a minute. There we go. And you can begin whenever you have a moment, whenever you're able.
Thank you very much, John, and it's a pleasure to be here. And it's a pleasure to getting a presentation from Global Fund in Mafu. It's great, and how they've worked, and they always continue to work with civil society. You can move, John. You can move the slides. Just move the slides again. I know that we're pressed for time now, so I'll make sure. So we are a research-based organization. We're an organization that believes in evidence-based programming and advocacy. So you'll see that it then fits very well with our partners that we're working with. We are part of a Campus coalition group, part of Africa partners, and also Global North partners. So for us as an organization, we feel this is quite a good opportunity as we work with other partners, Malawi, Tanzania, and also our Global North partners, in making sure that we can deliver evidence-based advocacy. So this is a good chance for me to share what we have done as an organization. You can move. So just to give a quick sort of a brief overview of what has been happening in Zimbabwe. So Zimbabwe, our health delivery system has been declining over years, over a decade or so, and also been exacerbated by the COVID-19 challenges that have been faced globally. I keep seeing these popping up. In 2021, our estimated GDP was at 26.2, with a growth rate of about 5.8. You can move. So our health spending trends from 2016 to 2021, just so to show what we have been using from our domestic budgets versus the external budget. We are still heavily reliant on external budgets that come through our development partners and big donors like Global Fund, PEPFAR. But it is very, very important for us as a country at this point in time to be unlocking domestic resources, as we are also looking at ending AIDS in 2030. We all sit down and think, what is the picture going to be like after 2030? We don't even know what is going to happen. I'm happy Linda is here. We don't even know what Global Fund strategy will look like after 2030. But as a country, I feel it's very critical for us to be unlocking domestic resource that can become key to our transition to funding our own national health delivery system. You can move. So like I was mentioning earlier on, you can see that our external partners have been stable in terms of what they've been contributing, and we saw a bit of a decline from 321 million to about 96 million in 2019. So this, of course, with macroeconomic environment that was struggling during that period, we had quite a number of issues around our Zimbabwean dollar versus us using the external funds like the US dollar. You can move. You can move, John. So trends in nominal and real actual health spending. So we look at our Ministry of Health, the budget did increase from 2020, where we're receiving about 684 million to about 2021, I'm happy to announce that there was a lot of advocacy from civil society and also other partners that then led to this push, which saw an increment in the fiscus by our Minister of Finance. So this we also do contribute towards some of the evidence-based advocacy that we have been pushing, Campus and other partners. But I must say that, you know, as a country, we have signed to the Abuja Declaration, and it would be good for us to then be matching the 15% Abuja Declaration. We are just 2% shy of that. Currently, we're at 12.7, which is approximately 13%. But we hope that, you know, with the ammunition and all the zeal that we have within the sector, the civil society sector, and the partners that are working with us like Global Fund, will be able to then push for more resources from the next national budget, which already the budget consultations have been done, and we have participated, we have taken part. We hope that we'll be able to then push for more resources towards health. Can move. So just to look at also what has been happening with the research in Zimbabwe, investment in research. I think this is one area where we need to encourage even our government to say that there's been, you know, lack, you know, of that political will and will to invest in this area, but which becomes key as we go forward. You know, we want to research in terms of even the disasters that we are facing. We've got COVID, and there are other disasters that we also meet as a country. So we feel that it is very critical for us to be investing in research. Can move. So what could be some of the constraints? Of course, the lack of funding, which I've then mentioned, but also we need to have, you know, the skills within our researchers, and we also have an aging sort of pool of researchers. Most of our renowned researchers are also aging, so we need to also see the young people jumping onto the wagon and also being trained, and mentorship coming from the aging researchers. Also, the issues to do with poor infrastructure and the coordination of the whole process. So for us, it is really critical for these 6 areas to be addressed so that we can improve in terms of investment in research. Can move, John. So what have we done to push for domestic resources for health? So I'm happy that earlier on there was a presentation, and there was from Francis, and there was the mention that, you know, engagement with key policy and decision makers is very critical. So as an organization, and with our partners such as ACT, Advocacy Core Team in Zimbabwe, others like Avrodad that we've been working with, we've been able to engage the Minister and Ministry for Finance and Economic Development to show them the need to increase funding towards health. And I'm happy, like I mentioned, that in 2021, we then saw an increment, which I think we can, if we follow the trend from 2019 with a single digit, and then we saw an increase in 2020 and 2021, quite close now to the Abuja Declaration. Also, key engagements with our parliament, and in particular, portfolio such as the budget and finance, and also the portfolio for health. We've also taken to strategies of using what we call champions. Some of those parliamentarians that we see are keen on health, are keen to see an increment in health budget. We're also working with other partners that already have MOUs, so leveraging on what they have already, working with Parliament. That has also been very useful. We also looking at participation within budget consultations. Recently, we already had a national budget consultation for Parliament, and we made sure that the communities and some of our partners also did take part. You can move, John. So of course, our biggest win, like I said before, was that increment. So what are some of those innovative tactics that we have utilized as an organization to make sure that we do push and also to celebrate the result where we have seen a move towards the 15% Abuja declaration, utilization of existing platforms, parliamentarian network platforms, and I'm happy that also we do have the national financing dialogue that's coming, and as a country we've already done the pre-dialogue to that in preparation for that, and we're already in the process of coming up with a press statement to then usher us into that dialogue next year, 2023. Also coming up with petitions, position papers that we then bring to the necessary authority, the rightful authorities, and make sure that our asks are then delivered to the right ministry, to the right authority. They also CSO priority papers. As an organization, for the 2021 budget, we made sure that after the budget consultations, we then called a breakfast meeting with the key parliamentarians who had been part of the budget consultations and civil society, and made sure that our priorities were entered the last minute, making sure that they are in, and the Minister of Finance would be able to read those. Then also participation in budget consultation. And what is also very important is to know that the budget, that engagement does not happen when the budget is out. Engagement starts early with the literacy for our citizens, making sure that communities are aware, so that even when the budget consultations are happening, people have got critical information, people are aware of what they need to be looking at, what needs to be contributed, and CSO priorities already in place and charters. Also utilization of data, CLM data, community-led monitoring data, and also human interest stories. We are happy that as an organization, being a research organization, we've been able to also collect human interest stories that come from communities themselves that are using the services. This also then helps us in terms of improving the quality of health service delivery as we engage the necessary authority, and also hear the Minister of Finance himself and higher authorities, evidence-based advocacy that then bring positive results. Can you move, John? So what are the other innovative financing that we have also seen as a country? Currently, we as an organization and our partners, as I mentioned before, we have been also engaging the Ministry of Transport and the insurance, so that we can get a percentage from third-party insurance allocation towards health. We've been pushing for 10%, because what we have seen is that there is a lot of funds that have been contributed towards third party, and there's no accountability or even transparency in terms of how these funds are being used. So we're pushing for that, and I'm happy to announce that even the Ministry of Health are now also sitting down and crafting also a paper in terms of proposal of how this third-party insurance can be utilized. For us, this is also a huge win. Also, we were also participating in the SDR Zimbabwe, the Special Drawings Reserve. Zimbabwe got a quota allocation in August 2021, about 960 million. And as part of campus partners, we came together and sat and deliberated and came up with a paper that we then shared with the minister. The minister had already mentioned that they were looking at vaccine and infrastructure, but it is good that we also had other areas that we felt they could look at: human resources for health, investment in around impact of COVID, disruptions of COVID. So there's also the special airtime levy that we have in Zimbabwe, 2% contribution. However, this one has not yet really been clear in terms of now tracking and accountability in terms of how those resources are being used. But upon its implementation and upon its inception, the talk was that a percentage was going to come to health, which we will still follow as civil society, so that at least we are watchdog and make sure that we keep the government accountable. Other development partners, Global Fund, I'm happy they're here. PEPFAR also been very useful, and as you heard from Linda, in terms of making sure that we continue to have the much needed medication and drugs for people living with HIV. So we are excited, and we still know that we are still receiving a lot of funds from Global Fund that have at least helped us to make sure that we can improve the quality of life of our populace. Private-public partnership, also an area that Zimbabwe is clearly now outlined in its national documents and said this is an area we should explore, and more players are now coming into play. Thank you. Social contracting, also quite an interesting area, as we have a 3% AIDS levy that has been levied on all the workers in Zimbabwe, and National AIDS Council has been responsible for this fund. But for us to improve in terms of transparency and accountability, we've been pushing for social contracting to be adopted. I'm happy that this is also one huge success and win, where now at least in every province, 10 provinces of Zimbabwe, 2 civil society organizations are now receiving money from from the AIDS levy, and also in particular people living with HIV also receiving their quota as a sector. So resource tracking, earlier on it was mentioned, we just don't want to think about receiving resources, but we also want to think about sustainable resources and how can we make them sustainable. How can we have sustainable health financing when we can also be able to track? So as an organization, we've been pushing for public expenditure tracking surveys that we can then utilize to then see if a minister today announces that, yes, it's 13%, we also need to track a year down the line, was that dispersed? And we need to monitor. When it was dispersed, it did get to the final beneficiaries. This also goes to emergency funds, such as the funds for COVID-19. So this, for us, we realized even through some of the oversight reports that came from CCM, sometimes we have resources that are lying idle and people not utilizing them in facilities. So if this is picked through the tracking system, it then improves the efficiency in terms of utilization of those resources. You can move. So some of the recommendations as an organization to us as a country and to our ministry, we also, encouraging that, in the next fiscal announcement, we hope that we can then match or even surpass the 15% Abuja declaration so that we can be able to provide quality health to the citizenry of Zimbabwe. Also, the need to be safeguarding the resources that we get is also a need for us to be able to track those resources and make sure that they're utilized according to the initial intention. It is imperative also for Zimbabwe to put in place mechanism, culture of drawing and research, results to inform policy. We really need to have a strategy that can guide us in terms of research so that we can inform our policy. Also, issues of funding health researches is in a key solving. But also what is critical is for the citizens to also have access to key documents such as the Blue Book. Those documents should be accessible to researchers and be able to derive meaning from results that are coming from the researches that are already conducted within the ministry and by the country itself. Thank you very much. I hope I was not too fast. John had already asked me to make sure that
no worries, no worries. It was perfect and it was great. I appreciate your flexibility and thank you for the presentation of showing us what are some very innovative, and I see a lot of movement in the chat. This is great, of ways that we can move forward. One last presentation by an advocate. Atu, are you available? I know that you are on the road, but I just wanted to make sure that you are available to say some words about your work in Tanzania. Please unmute. Are you able to?
Hello, John. Hey,
yes,
John.
We can hear you. We can hear you.
Yes, thank you. You can you share the presentation? I'll be very quick.
Okay, no worries. I can do that. Thank you everyone for sticking with us. Some great presentations means sometimes you go over time. So there you go. Atu.
Okay, hello.
Yes,
hello everyone. Thank you for this opportunity, for giving me this opportunity to share with you on what Tanzania is doing as far as health sector budget analysis is concerned. So Sikika is a non-government organization that advocates for access to quality health services to all Tanzanians. And we have been, our advocacy as it is, it's evidence-based.
Atu, you froze. I don't know if you can hear me. We're unable to hear you.
But for this particular one,
okay.
We have do the health sector. John, next slide. When we do the health sector budget analysis, our main document that we use is the health sector strategic plan, and trying to see what is the allocation, the costed vis-a-vis the actual allocation in each year. So if you look at those graphs, you'll find out that the health sector budget allocation has been below 50%, as you can see in the graphs. So the costed budget is way high, and then the actual allocation is below. And one will ask, self for himself on how the implementations of the health plans can be achieved with these trends of health sector budget analysis. Next, please. And when we do the analysis, we normally use the volumes, those books, and also looking into the current budget vis-a-vis the development budget. And in this particular budget, we also focus on being the advocacy organization, a coordinator of the Compass Coalition in Tanzania. We also look into HIV/AIDS to determine how much is allocated from the government comparing to what is coming in from the other sources, including the Global Fund and the other development partners. Next, please. So before we look into how much is allocated for the health sector, in the health sector, we look overall on what is the government allocation, where are the priorities. Sorry, this is the overall government budget, not health sector budget. So the health sector budget 22-23 is 2.1 trillion out of the 41 trillion of the overall government budget. And you can see the health sector budget share, which is just colored in, sorry, the color very, very limited. If you look if you compare from what has been allocated from this year, you'll find out that there is a decrease comparing to the last financial year. You'll find out there is a decrease of 9% from the previous budget, which is to about 2.4 trillion. But why there is this decrease of funding this financial year, which is 2022-23, is because of the COVID-19. Remember now, last year we had a big chunk of money coming in to address issues of COVID-19, and this was mainly from the development partners. Next, please. And again, we look into the development budget, comparing to the recurrent budget. And for the financial year 2022-2023, there is slightly big budget in the development comparing to the recurrent comparing to the development budget. And the development budget, the main contributors are mainly the donors, but there is a slight a significant contribution as well from the government as well. But again, the development budget normally go for establishment of infrastructures like the health facilities and the like. Next, please. Yeah, we have tried to look into the trend of the allocation of the development budget by vote, and we have seen there is a significant decrease of the development budget, particularly from the development partners, as you can see in the graphs. But again, a slight increase from the government, which is colored blue. So which again, as I've said, that the main of the development budget goes for the is we as the CSOs are trying to look into the functionality of the newly established health facilities. And for the last year, most of the funds that were coming from the development partners, especially for COVID-19, were directed for establishment of infrastructures, but the functionality of the infrastructures are in question because the pace of recruiting the health workers to work in those health facilities has been very slow compared to the speed of the building and refurbishing the old health facilities. Next, please. Yeah, and we also coming to specifically for the sector budget by vote. Can you make a little bit bigger, John?
I can't make the slide bigger on my end. No.
Oh, sorry. I'm struggling to see. I have issues with my side. So again, we have seen, and I will try to focus on some of the areas. Like our interest is more on the HIV/AIDS. And if you look at the green color, which is the TACAIDS, Tanzania Commission for HIV/AIDS, there is a significant increase of the budget allocation, and of which this is the area of our advocacy. And we have been doing this for years now, since we joined the Compass through AVAC support. And we have been sharing the findings, particularly on HIV/AIDS, which depends more on the development partners. We have been sharing the findings with the Minister of Health, as well as the Parliament, trying to advocate for increased domestic resources to support the TACAIDS to be able to address, to respond to HIV/AIDS interventions. And one of the questions that we have always been asked by the parliamentarians and also the councillors at the council level is, where do you think could be the sources of the funds that could support the HIV responses? But we have been asked to do a scientific research and come up with findings that will help push the agenda forward to see what could be the other sources that can contribute to increasing the funding, because the current approach is that the targets has established the ACE Trust Fund, that the main role is to do resource mobilization, but the approach that I've been doing quite not meaningful, because they depend more on marathon, and sometimes on dinner garage, where they invite business people to come and contribute. But this one the approach has not been sustainable, because the contribution or the amount that they get from that source is not that much significant. So what we, as a civil society organization, we are trying to find out where the government can tax or broaden the tax base that can go directly to HIV/AIDS. Next, please. These areas could be a bit perhaps unrelated, because not quite relevant to the HIV/AIDS. So the yellow highlights the budget for the health commodities that in the previous year, we did not see the health sector, the budget for the health commodities was allocated in the strengthening of referral hospitals. And for the CSOs, it was difficult for us to track on how much specifically the government has allocated for health commodities to enable the citizens to be able to access the services. But again, we had a dialogue with the Minister of Health, as well as the members of Parliament, to influence that the budget for the health commodities be separated, so that we are able to track on how much budget has been spent on which commodities have been purchased, and how much has been, and which one, whether have been reached to the service users at the health facilities. So this year they have responded, and that's why you can see the 200 billions in the yellow highlights. So I've spoken about the HIV/AIDS with the increase that we as Sikika and the other partners of the Compass Coalition and others are celebrating, that we are seeing an increase of the budget allocation for the HIV/AIDS. But the question that we have, we as civil society organization, is the utilization of this budget to see whether really the people living with HIV/AIDS and those whom the groups that are affected with HIV/AIDS benefit from this increased budget. Next, please. Again, next. Next again. Yeah, maybe to conclude, we have seen again this year there is a slight increase of health budget for the human resources for health, but again the allocation has increased from 1% to 13%. But what we are following up, we as non-state actors, is to ensure that the newly recruited healthcare workers are equitably distributed to the rural areas, to ensure that people in the hard to reach areas also are benefited from the this plan, and that the cadres that are recruited are able to respond to the needs of the community. And again, the increased HIV budget by 39%. I think that was a skip. The percentage has been not requited, indicated here. But again, in the analysis, we have seen that there is no budget for the health emergencies like COVID-19. So the country is still depending on external sources of funding. So in case of any emergencies like of recent where we have seen Ebola pandemic in Uganda, so the country was getting prepared to respond to it, to ensure that there is less impact in our country. But again, we have not seen any budget allocated for emergencies in the analysis that we have done. So this is the question, and we'll continue advocating for this, joining forces with our colleague to influence budget allocation for health emergencies such as COVID-19 and Ebola, because these are unforeseen pandemics. And again, the trend of health sector budget, again, mismatches the HSSP, the health sector strategic plan. So we'll continue with this advocacy to ensure that there is tax base being broadened, to ensure that there is coming from internal sources and that there is less dependence from the donors in ensuring that our community are benefiting from the resources that we have in country, because we believe that we have a lot of resources, the natural resources that we have, minerals, etc., that if they are well managed, the community will be benefited from the internal sources that are blessed by our Almighty God. So thank you so much, John, and I have to run to the airport. Thank you for your attention.
Thank you so much. I appreciate it. And thank you for everyone who has stuck around. We know that we are over time, but we thank you all for coming to this session. Ethel, I don't know if we have any time for discussion, unfortunately, but you could let me know if we have 15 minutes maybe for some, yeah, let me know what we can do.
I think we can give an opportunity if people want to raise their hand. If we do not see any hands raised, we will then wrap up, because we are very conscious of the time. There's been a lot of conversation going on in the chat.
Yes.
Nita, you're very fast. Go ahead.
Hi, everyone. Can you hear me?
Yes.
Okay, excellent. So the reason why I was very fast is I thought today was really motivating. The three presentations, they were really excellent in moving us as Africa forward. That's one, compared to the thread of what was said on day one about where are we, why are we not coming together, etc. And then yesterday was depressing, but today was great. So my second point really though for tomorrow, please, is to say, how are we in Africa together with our partners that John and everyone spoke about, going to come together to strategically implement short, medium, and long-term goals for research, for prevention. I mean, all of us have our own little corners. I'm focusing currently on access to the ring and access to cab LA. It's a big issue. It's personal. It's etc. But it's big. So that's my second point. The coordination of it. The third is all the speakers today really gave actionable suggestions, but they are broad. So tomorrow, even if we're going to create a subcommittee or a group in Africa, East, North, West, South, but subgroups so that we can share the national strategies that was raised by Global Fund. We can take what the private sector said about how and what we shouldn't do, which we are all currently doing, and John can attest to that. In terms of the thinking around manufacturing, full and I don't even like that terminology, because we've been doing this for 2 years with COVID. So those are my three critical points that I can only say verbally. Thank you for the opportunity. I appreciate it.
Thank you so much. So when it comes to the global kind of like action planning, short, medium, and long term, tomorrow, we will be focusing on decolonizing the system and global health equity. That session is pretty well planned, but there will be some actionable items after the week has ended, right? As I mentioned yesterday, I don't know if you heard, but we will be creating a domestic resource mobilization learning collaborative where we could do exactly what you are suggesting, speaking in regional terms or country level terms, bringing advocates from different sectors together, talking about different things about how we can actionably move domestic resource mobilization and investment forward, right? We are going to be trying to get advocates together to really share some of the documents, share best practices, share challenges that they are facing, and so that we can strategize as a coalition, as a movement together, and we're not leaving anyone out. So tomorrow we will be talking about decolonizing as part of the program, but there will be some action items and action steps with the domestic resource mobilization learning collaborative that we're trying to bring together with everyone who's registered for at least one day of this event will get that call to action to come together to really to talk about manufacturing, talk about research, talk about ring advocacy, talk about all of these different components that relate to domestic resource mobilization.
Thank you.
Yes. And did you have other points that I didn't touch on? Sorry.
That's okay. I mean, I'm not going to take time, but let's look at it's the how more importantly now than the what, because we know the what.
Yes.
People have shared the intellect.
Exactly. Yes.
Absolutely.
So
There's
the
a lot
action
of the
steps.
what in the chat, in the chat and the conversations that have been going on. There's a call to Robert has offered to collaborate in unlocking the private sector. And then also, Francis, the platform that you used for advocacy for health in Nigeria, you have actually very well put it that it is adaptable to various other advocacy initiatives that we have. So yes, the Learning Collaborative will be a great opportunity to strategize and take advantage. Also, Linda mentioned opportunity for advocacy in the context of the Africa AU Summit.
Yes, and I love that during this week, we are engaging Global Fund, we're engaging UNAIDS, we're engaging advocates, we're engaging the people, the stakeholders, government officials. We had the Africa CDC on day one. And tomorrow we're going to have more people on to talk about decolonization and how to make sure that this process is decolonized, right? As we talked about, a lot of the funding is donor driven from the global north, right? So how do we ensure that it is a decolonized process, that Africans are the ones that are creating the research agenda and manufacturing these tools, right? How do we make sure that the influence of the global north isn't overshadowing the needs of African citizens? So that is what we're going to be talking about tomorrow to wrap up. But tomorrow is not the end. Tomorrow is not the end. It's the end of Africa Health R&D Week physically, but it is not the end of this conversation. In reality, it is really the beginning, because we are just hitting the iceberg, the tip of the iceberg, right? We have to dig deeper and talk about the how we're going to do this and strategize as a continent, not as individuals, not as individual organizations, but as a coalition, as a continent of advocates and stakeholders and champions, and how we can move this forward. And thank you, Theophile, for putting your email in the chat. We will definitely be in contact. So we really appreciate it. If there are no other hands, I think we can close for the day.
Absolutely. I think we can close for the day. And as John said, this is just the beginning. So stay tuned. And thanks, everyone.
Thank you so much for staying an extra 24 minutes. Appreciate it.